All right, I see that it is 11 Central, noon Eastern. So to respect everyone's time, I'll go ahead and get us going. So good afternoon, good morning, depending where you're joining us from. And thank you for joining for Implementing Trauma-Informed Care, a hospital-based case review hosted by HCET with presenter Dr. Alyssa Conklin. My name is Jordan Greenwald. I'm the Training and Community Engagement Manager at HCET, and I will be moderating the webinar today. I would like to briefly introduce you to healthcare education and training if you're unfamiliar. HCT's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCT is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. This webinar does have closed captions available. To enable them on your screen, you'll click the Show Captions button at the bottom of your screen, then click Show Subtitle, and then you can change the setting by clicking, it either says Subtitle Settings or Caption Settings. Throughout the presentation, we do encourage you to send your questions via the Q&A box. To submit a question, you hover over the main screen, then select the Q&A icon at the bottom. Once selected, the Q&A box should appear. To send a question at any time during the presentation, please send it through this Q&A rather than the chat. This just ensures that everyone in the webinar can view your question, and you have the option to send the question anonymously if you choose. Please be sure to also follow us on our various social media accounts to keep up to date with the newest information and events. Now, I just want to quickly review some housekeeping info. A link to complete an event evaluation will be sent to you in the chat at the end of the webinar, as well as via email following this training. Your feedback is greatly appreciated, so please fill that out for us. Archived presentations and a list of upcoming events can be viewed on our website. And if you have any technical difficulties during this presentation, please either reach out to me via the Zoom chat or email updates@hcet.org. Nursing contact hours are available for this webinar as well. To receive your nursing contact hours, you must attend the entire webinar, return the completed participant evaluation / post-test, and then complete the nursing contact hour form and email it to kbradford@hcet.org. And that form will be included in the email that I send following this webinar. No one with the ability to control content of this activity has a relevant financial relationship to disclose with an ineligible company. And now I will turn it over to Dr. Kara Berg-Ronick to tell us a little bit more about the Midwest Trauma Informed Care Training Center and to introduce Dr. Conklin as well.
Awesome. Thanks so much, Jordan. Thank you all for joining us today. We're thrilled to have you. Again, I'm the director of the relatively newly launched Midwest Trauma Informed Training Center. In response to community need, HCET launched MTITC, making in-person and virtual training resources and technical assistance in TIC available to healthcare providers across the Midwest. Our goal is to transform the landscape of health and human services by equipping professionals with the knowledge, skills, and support to provide TIC as standard care for all. To learn more or to partner with us, you can email updates@hcet.org. I also want to acknowledge and appreciate the funding for this webinar that came from the Indiana Department of Administration on behalf of the Indiana Family and Social Services Administration for Hoosier Families First Fund Maternal Child Health Programming. Here, you can go to this QR code to join our mailing list to find out what we're up to and upcoming events. You can also, again, email updates@hcet.org, and then you also have my contact information should you have any questions or be seeking a presentation or anything else for your organization. This second QR code, they are different, is a survey that the Midwest Trauma Informed Training Center has launched just to ask you what you need, what would be the most helpful, what you're seeking. Again, we're about a year into our existence, and we are just hoping to find out the path forward so that we can serve the most people the best way possible. So please go ahead and take the time to do that. Also, we'll be sending this link out on that listserv. So if you just want to sign up, that works too. And now, without further ado, it's my total pleasure to introduce you to your presenter for the day. She is incredible. Dr. Alyssa Conklin is an assistant professor in obstetrics and gynecology at Indiana University. She is also the director of the Generalist Division, the medical director of Coleman Clinic, and the medical director of Indiana University Health Midwifery. Additionally, she is the co-chair of the Women's Health Task Force in Indiana Perinatal Quality Improvement Collaborative, which is a statewide collaborative aimed at decreasing maternal morbidity and mortality throughout the state of Indiana. She and I co-run the subcommittee on trauma-informed care, so she's a joy to work with. Additionally, within her clinical practice, she's been practicing trauma-informed care for more than 10 years, including the gentle or family-centered cesarean birth. She's my favorite. So you're in for a treat. And here is Dr. Conklin.
Okay, thank you for that lovely introduction. I greatly appreciate you. As Kara said, I am Dr. Conklin. My pronouns are she, her, and because part of what trauma-informed care does is honor the whole person in front of you, I'll also share that I am cisgender, pansexual, married to a man who immigrated from Ecuador, who still proudly displays his 99-cent American flag on our mantle at home that he received during his naturalization ceremony. We have 2 sons, aged 11 and 8, a geriatric Scottish Terrier who is impressively deaf. We also have 6 chickens and 2 tree frogs. I'm also getting over a cold, so I may mute myself briefly once in a while if I need to cough, so you all do not have to hear that. These are our objectives for this webinar. Knowledge is certainly power, and since we often have a wide range of professions on these webinars, we will begin with some basic foundational knowledge on what defines trauma and what trauma-informed care is. This will be our guide throughout this talk. And we will start with what is trauma and what are ACEs, or adverse childhood experiences. For those of you who attended the January webinar on trauma-informed care, the next few slides will be a little repeat of what we reviewed then, but this is important information to share for those who were not at that webinar, so we can all be at the same level of understanding. As we reviewed in the January webinar, we defined trauma using the definition by the Substance Abuse and Mental Health Services Administration. Trauma is something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful or even life-threatening, and that has lasting effects on the individual's functioning and well-being. Notice the 3 E's of events, experience, and effects. When it comes to what is trauma, it is the experience that is key and the individual person who decides if a given experience is traumatic or not. And the same event that can be experienced by one person as traumatic may be just the opposite to another. An example in our OBGYN world would be the experience of a C-section. One person may truly prefer this type of delivery and feel empowered in that decision. Another person may find a C-section to be one of the most traumatically impactful experiences of their lives, perceived as a failure of their body or their goals or their self-image. And they could be reactivated or reminded of that trauma every time they look at their body in the mirror or every time they go to the gynecologist's office. Categories of trauma are broken down further into acute, like a one-time sexual assault, chronic, like domestic violence in the home, complex, like loving someone with a substance use disorder, and historical, like forced sterilizations, forced relocation, and slavery. And you can see the definition of all these types of trauma in this icon on the right. So trauma, which is any event determined by the person experiencing it to be traumatizing to them, can occur at any age. A different and well-studied form of trauma is defined by only occurring to those under the age of 18. These childhood traumatic experiences are known as adverse childhood experiences, or ACEs, and are very much associated with poor long-term health outcomes. There are a total of 15 ACEs that have been linked to poor health outcomes. The original 10 on the right include abuse, neglect, and household dysfunction, and really focus on family-level adversity. The additional 5 ACEs here represent community-level adversity and have also been shown to have negative impacts on long-term health. ACEs are incredibly common. From the original 10, 64% of people have at least one ACE, and 12.5% have 4 or more. In fact, before we talk about the impact that ACEs have on healthcare, I would encourage all of you to take a moment and really look at these 15 ACEs. What is your ACE score? You don't have to say it out loud or type in the chat or anything. Just take a minute, look at them, and think about it. Maybe your ACE score is 0. If it is, I hope you can see how incredibly lucky you are. But I'm betting there are several folks on this talk today who have high ACE scores. Now we'll briefly review the long-term negative impact that trauma and ACEs have on our health before we dive into trauma-informed care. The more ACEs a person has experienced, the more likely they are to have any of these negative health outcomes. For example, people who have experienced 4 or more ACEs are 12 times more likely to have attempted suicide, 7 times more likely to be an alcoholic, and 10 times more likely to have injected street drugs. This matters quite a bit in the state of Indiana, where the #1 cause of pregnancy-associated deaths in 2020 and 2021 was drug overdose. Additionally, the CDC states that at least 6% of all cancers could be prevented if children did not experience ACEs. There was even a study showing that the more ACEs a person experienced, the more likely they were to refuse the COVID vaccine. How common are ACEs at home in Indiana? Well, nearly half of children have experienced at least 1 ACE in Indiana. Hoosier youth, in fact, have a higher prevalence than their peers nationally, and 8 out of 10 ACEs as measured by the National Survey of Children's Health. So now that we know what trauma is and what ACEs are and the impact that those can have on our health, let's review what is trauma-informed care so we can then dive into some cases. Trauma-informed care is a whole person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. A trauma-informed framework assumes that everyone has a trauma history and that medical evaluation and treatment themselves are potentially traumatizing. It acknowledges that a patient's life experiences will impact their perspectives and priorities when engaging in the healthcare system, and that awareness of these perspectives has the potential to improve patient engagement, treatment adherence, and health outcomes. Trauma-informed care is not the same as providing trauma-specific services, such as treating a broken leg or the sequelae of a car accident. And importantly, disclosure of a past trauma is not necessary to provide trauma-informed care. Rather, the foundation of trauma-informed care is the assumption that all people carry past traumas and that all people benefit from this type of approach. This is called the universal precautions model, like donning gloves before we examine a patient. Why do we wear gloves for an exam? We assume anyone could have a bloodborne illness, right? And that assumption has become so consistently a part of our care that we don't even think about it consciously. We just put on our gloves. Trauma-informed care should be applied with the same universal precautions model. Assume everyone has a history of trauma and you'll never go wrong. You'll put those proverbial gloves on for every patient and approach every patient with a trauma-informed lens. We utilize the 4 R's created by the Substance Abuse and Mental Health Services Administration, which states that a trauma-informed approach is one that realizes the widespread impact of trauma, recognizes the signs and symptoms of trauma in clients, families, and staff, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. This 3-minute video is a great introduction to trauma-informed care and the impact that adverse childhood experiences can have on a person's lifetime, as well as a brief overview of what we can do to implement a trauma-informed care approach. It introduces what is really the key paradigm shift of trauma-informed care, shifting your thinking from what's wrong with you to thinking more, what happened to you?
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have 1 ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made, plus our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, so now that we know what defines trauma and adverse childhood experiences, and we understand the foundation of what trauma-informed care is, let's dive into some cases that are based in the hospital. The first will be a case on labor and delivery. So our first patient is a 19-year-old African-American woman presenting in labor at 38 weeks with her first baby. You review her history. She has no medical problems. She's not had any surgeries. This is her first baby. She denies any history of sexually transmitted infections. Her partner is with her and supportive, and she is currently living unhoused. And her mom has ongoing struggles with substance use. So you have her history here. What are the clues in her story that might point to any ACEs? Feel free to type it in the chat, anything you might note from her history that signifies an adverse childhood experience. For easy reference, I'll list those 15 known ACEs here. And I don't know if somebody can monitor the chat here.
I will.
Thank you. Feel free to type in there any ACEs you might notice from her description. Mom has a history of substance use. Yep, nailed it. Been in a shelter. True. Living unhoused. Any others? Can you think of any others? Those are kind of the two obvious ones, right? So we know for sure that she has that history of substance use in her family, and her parents are not together. Also, she's Black, so she's likely been subject to racism in her life. Keep in mind, you've got that list of ACEs there on the right. But as with most people, we simply do not know what other ACEs she may have experienced. Was she ever in foster care? Any history of abuse? Her mother struggles with substance use. Is that related to underlying mental illness as a form of self-treatment? Has anyone in her family been incarcerated? What about neighborhood safety? Without her sharing this information with us voluntarily, we just wouldn't know. Now, what clues may point to a trauma history? Let's review. She's a pregnant teen. Her partner appears supportive, but we do not know if this conception was consensual or not. She's living in a shelter. It turns out she was living with her mom, who was using substances around her. And when her mom was using the substances, she would get verbally and physically abusive to her. So she moved into a shelter on her own. She just got a job at a restaurant where she met her current partner. She actually did conceive this pregnancy through sexual coercion because she was staying at a friend's house when she first left her mom, and her friend's boyfriend sexually assaulted her. She actually wants to keep the baby. Her current boyfriend knows about her history and is supportive of her and intends to raise this child with her. He just got a job as well, and they are saving to get an apartment. You would only know that if you ask and if she's willing to reveal this, but that's why the universal precautions model for trauma-informed care is so important. Just like how we put on gloves to examine every patient, you really have no idea what is hidden under the surface when you're interacting with anyone. When it comes to admitting someone to the hospital, how do you go about that admission conversation? This is where providers gather the information they need to adequately care for a patient. Do you do this in front of others in the room? Do you ask them to leave? Do you ask the patient what they would prefer? While the latter may seem the most altruistic and giving the most power back to the patient, if there's an abuser in the room, the patient will rarely say that they want them to leave. And that's because a request like that would likely be a source of retaliation from the abuser at a later time. Be intentional about how you are doing this, how you're taking that history from patients. What do you do when you see or hear a red flag? There are many ways to address these, and some are ineffective or may even be harmful, like asking about abuse or if the pregnancy was conceived consensually in front of others. But there are two important points when gathering a patient's history. One is to be intentional about how, when, and around whom you gather this information. Excuse me, this information. I'm gonna have to mute myself for a second. I apologize. If I can. Excuse me. And two is to be both on the lookout for any concerning history points that may put this patient at risk, and also to have an intentional plan to address them. So as we likely all know, when someone is in labor, at some point, it is highly likely their cervix will be examined. As you can see in this model here, by its very nature, it is intimate and a potential source for trauma and reactivation of traumatic experiences. And to even get this exam done, the patient has to separate their legs and allow this person into their very vulnerable and often very exposed space. Here's a picture of a laboring woman having her cervix examined. And do you see in this picture how the examiner is also holding her leg? How activating could that be? Do you see all the vulnerabilities here? I mean, here's a picture of me in labor with my first child. I'm exhausted. I've got an epidural, so I can't run away. And my mom is having to hold my leg while they check my cervix. I trust my mom, so I feel safe here. But how many patients don't actually feel safe with the people in their room? In this example, the provider is standing over the patient, as is frequently the case. So there's a physical power dynamic here. If you're a provider who performs cervical exams with patients, next time you examine someone's cervix, try to be fully aware of how you're positioned, how the patient is positioned, what is exposed. Can you cover any areas up that don't need to be exposed? Are you explaining every step of what they're going to feel first and then examining them, etc.? Be aware of how your posture, your words, and your physical touch can potentially activate a person's past traumas. When it comes to the actual delivery, how is this done? Frequently, many people come into the room beyond the labor nurse and physician or midwife. For us, this makes sense. Everyone has a role, but it often happens without explaining or asking the patient. And this brings up the very important point of consent. Consent is something that should be unmistakable, often verbal, uncoerced, freely given, reversible at any time, specific to the situation, and informed. We have to honor that this patient is welcoming us into their space. It's not the other way around. They have the right to say yes and the right to say no, and we have the responsibility to explain the risks of their decisions. So here's a picture of me delivering my first child, and the delivering person is very much all up in my business, as is always the case during delivery. It all looks good and fine, right? But in fact, during this delivery, she did something to me without my consent, using scissors to cut an episiotomy, even though there was no medical indication. For those of you on the webinar who are obstetric providers, you can actually see the fetal monitoring in the upper left corner, which is legit category 1, if I do say so myself. And I pushed him out, my first baby, in only 20 minutes. So there was zero indication for that episiotomy. And it was a large medial-lateral episiotomy. So if you know, you know, right? Recovery from that kind of stuff is painful. This happened to me after I was already a practicing OBGYN with a lot of knowledge and privilege. Most patients do not have that power or that knowledge. Most patients do not feel like they have a voice. But how many of them would speak up if given the chance? If we created for them a space where they felt safe enough to do so. As a delivering provider, I recognize the importance of this, and I make a point with every interaction with every patient to try to create space for them to feel safe, to speak up, and to know that their voice matters. Do I succeed every time? No, I don't. but I am intentional about trying with every patient. So for this case, So we're going to move on to our second case. This is a social work interaction. For this case, we're actually going to stay with the same patient. So as a reminder, she's 19 years old. She just had her baby. The delivery went well, and she is now over the moon happy snuggling her newborn. The next day, someone knocks on her hospital room, and it is a social worker. She introduces herself, and while she begins telling this patient why she is here, the patient internally is freaking out because unknown to anyone else is that she spent a few years in the foster care system as a child while her mom was incarcerated for issues related to her substance abuse. She has trauma related to this, and she associates social workers with that trauma and is feeling fully activated right now. So while she is internally panicking and activated from her past traumas, she finds enough strength to ask the social worker why she is here. The social worker tells her she was consulted because this patient's urine drug screen on admission was positive for opiates. But here's the first thing. She never consented to this testing. In 2001, the Supreme Court actually ruled that healthcare professionals cannot get a urine drug screen from a pregnant person without their consent. 29 of the 30 women who filed in this case were Black. In fact, Black women are statistically far more likely to get a urine drug screen on admission to labor and delivery than white women. Many hospitals in this country do not have policies regarding urine drug screens. Ordering them is left up to provider discretion. The lack of these policies continues to widen the gap on disparities in healthcare and fuels implicit bias and, quite frankly, overt racism, and is yet another example of policing Black and brown bodies when these medical tests are weaponized against patients. The other interesting point here, which will go ignored in the dominoes effect that will occur to this woman because of this unconsented drug test, is the fact that she does not actually use drugs. She actually had cravings in this pregnancy for, wait for it, everything bagels. They're so good. Well, this patient binge ate 5 to 6 of these in the last 2 days, and it turns out that is why her urine drug screen is positive for opiates. Did you know that's possible? It's the poppy seeds on the seasoning that's the culprit. But guess what? The hospital, while illegal in having urine drug screening without consent, does have a policy that once a urine drug screen is positive for anything, social work must get involved along with CPS. Can you imagine how traumatizing this is for this patient? And this story of an everything bagel, seasoning obsessed pregnant patient with a urine drug screen positive for opiates is a real story and was published in Newsweek just last year. So, how can the social worker practice trauma-informed care in this setting? The first step is gentle introduction and non-judgmental probing. If you use the universal precautions model that trauma-informed care is based on, you will assume this patient likely has a history of trauma. Also pay attention to your approach and stance. Are you standing? Do you sit? Think about the power dynamics communicated through how you position yourself, as you can see in these pictures. Trust and transparency are key to trauma-informed care. Kindness and conversation without judgment are absolutely key to building trust. Are you able to listen to this patient without bias and preconceived notions when she tells you she doesn't use drugs? Also consider your power and position to advocate for this patient and, quite frankly, all patients in the future. Does your labor and delivery unit have a policy for urine drug screening pregnant patients? If not, consider advocating for this. A urine drug screen policy helps care become more equitable, and that is one part of trauma-informed care. So now we'll dive into our third case of the day, an emergency room visit. You're a provider working in the ED. It's really busy. You've already seen 20 patients and it's only 4 hours into your shift. And to be frank, you are feeling a little overwhelmed with your caseload. The nurse who roomed the patient gives you a quick handoff. This is a 28-year-old who had a C-section a week ago and is complaining of abdominal pain and foul-smelling discharge. This has been slowly getting worse since a few days after the C-section. The nurse gives you the vitals. They're all normal except a temp of 100.1. You quickly glance through the chart and then you go see the patient. So you have the history here. You knock on the door, you introduce yourself, and you walk in. Then you see 2 men in the room. One appears to be the patient in a gown and on the gurney, and the other support person in a chair against the wall holding a baby. You're confused because you thought you walked into the correct room, but the patient you were trying to see had a C-section a week ago, and this room has only men in it, so you feel you must have made a mistake on the room number, and you say, "Excuse me, I must have walked into the wrong room," and you step out. You double check the room number at the nearest computer, and it says the correct number for a post-operative C-section patient. So you take a few more minutes to dig more deeply into this patient's chart, and that's when you see the patient is transgender. You decide to take a few extra minutes to dig through this patient's chart to better understand his history. You note the patient's legal name is Samantha. This is also known as a dead name, which refers to the name a trans person is given at birth. Many trans folks never want to hear that name and may also have trauma associated with just hearing it. His actual name is Andy. This is where we battle electronic health records inadequacies. I'll show you two of the EHRs we use in Indianapolis to highlight this challenge. One is Cerner. Do you see anywhere where a person's actual name or pronouns are up in that blue area where the patient identification is? No, right? Well, do you see that small little I on the opposite side of the patient's name right here? If you hover over that, this box pops up and it will tell you the patient's pronouns. This has to be manually entered. The actual name also has to be manually entered and appears only in parentheses next to the legal name, like it says Mickey here next to Mickey. Another EHR is Epic, where there is also a little I under the name, and if you hover over it, this box pops up that shows their pronouns, gender identity, sexual orientation, and anything else that has been manually entered. These invisibilities highlight how difficult it really can be in these electronic health records to electronically advocate for patients who are transgender. So you continue the chart review and you note he had an elective, unlabored C-section at term a week ago. He's married to a man. His husband has HIV, but Andy does not. And though you note he's not taking PrEP, and there doesn't appear to be a conversation about this in any of his notes. He had top surgery years ago and they are formula feeding the baby. Also, he had an IUD placed during his C-section. Now you're about to go back into his room. How do you proceed? There are certainly good ways and bad ways to re-engage in this encounter. A bad way may be to walk in and not acknowledge the mistake you made in not being prepared for this patient. There is also certainly an opportunity here as well in communication with the nurse who gave you the handoff and did not mention that he is transgender and what his actual name is, since we all have a duty to advocate for our patients, and this includes adequate and appropriate handoff, but that's for another time. So you knock on the door and you do the right thing. You acknowledge your mistake, you call him by his actual name, you share your pronouns, you ask for and acknowledge his pronouns, and then you are both able to move on in a positive way. When it comes to history taking and also the exam, there are also good ways and bad ways to proceed. A bad way would be to assume you can use the typical anatomical terms for his anatomy when discussing his concerns. A good way would be to say, before we begin, is there any language or terms that make you the most comfortable in talking about your body, or any terms I should avoid? Honestly, I usually have a pretty casual rapport with my patients, so I might even say, what terms do you use for your downtown parts? Really, the point is ask in a way that is comfortable for your vernacular and gives the patient a chance to tell you what they need. Once you have that information, you can then both speak on the same level of understanding and respect. This may seem minor, but if a trans man does not use traditional anatomical terms for his parts and you use those terms when talking to him, that is continued microaggression and repetitive trauma every time you speak those terms. So you take that time, you get the terms he uses for his body, he is comfortable with traditional anatomical terms, and you dive into your conversation. One important thing to remember when seeing a patient who is trans in this type of setting, while you as the provider may have zero issues about doing an exam, I guarantee you the elephant in the room for that patient is what kind of an exam are you planning to do? I would advise anyone caring for a trans patient in this setting to bring this up as early as possible to help address fears and come up with a plan as a team with the patient. A bad way to address the exam would be to have the mindset that when any 1 week post C-section patient comes in with these symptoms, you will always do a speculum exam. You may not actually need that part of the exam to diagnose this patient. So a good way to approach the exam would be to ask the patient what fears they may have about their condition and about the exam. So you do that and he tells you he just wants the pain to stop and would really like to avoid an internal exam if we can. You dive into his history and he tells you this has slowly gotten worse since about 2 to 3 days after the C-section. It's worse with walking, so he walks really slow. It's worse with getting up from sitting, having a bowel movement, and coughing. The bleeding is lightened up, but now a discharge that smells bad is coming out. It's not a lot, but it doesn't smell right. Next, you need to perform an exam. But what kind of exam do you truly need to help cinch this diagnosis? It's okay sometimes to think outside the box of what you would standardly perform. You ask if he would be okay with you touching his abdomen only and just looking at his pad and vulva to look at the discharge, but no touching the vulva. He's cool with that. You also ask if he would be okay with an ultrasound so you can check the uterus and lining within the uterus, looking for any clots or retained pregnancy tissue, but say it would be fine to do that on the abdomen only and not do a vaginal ultrasound. He is so visibly relieved at that because he really wants to avoid an internal exam if we can. This is also a really great opportunity to highlight such an important point. His body, his choice. No one should be forced to get an exam they don't want just because they present for care. You can easily work with a patient to review what you recommend and why, and come up with a plan that is acceptable together. I like to take these opportunities to educate patients on self-empowerment. This patient never needs to have an exam without his informed consent or declination, and the informed part is our job. You ask if now is an okay time to do the exam and if he would be okay with a chaperone. He declines the chaperone. He is able to pull his own pants down for the exam, and you look. You can see a mild amount of discharge, but nothing extraordinary. His uterus is mildly tender, which you can feel on the abdominal exam. You then ask him to pull his own pants back up and you cover him up. Now it's time for the ultrasound. What do you normally do when you order an ultrasound? Normally we do nothing, right? We just wait for the ultrasound to be done and for the results to be sent. However, with a patient who is transgender, I would strongly recommend being more proactive. Again, imagine being the patient. They go to get an ultrasound. The ultrasound tech doesn't expect a transgender patient, and they make the same re-traumatization that you did when you first walked in that room. So consider calling the tech and letting them know he is trans, his name is Andy, his pronouns are he, him, and the ultrasound will be abdominal only. This takes seconds of your time, but goes such a long way in helping this patient feel safer in their care. So based on the exam, the labs, and the ultrasound, you diagnose him with postpartum endometritis. You feel based on his findings, he would likely do fine without inpatient admission, and this is what he wants, and you discuss this with him. You prescribe antibiotics, arrange a plan for close follow-up, and review all the reasons to return to the ED. But what about PrEP? You could do nothing more at this point, right? You've done your job, you've diagnosed and offered treatment for his presenting condition. But you have this opportunity to at least let him know about PrEP and why it can be helpful in his situation. How do you bring this up? Well, be intentional. You can certainly state, I see your husband has HIV and that you are not on PrEP. Have you ever heard of PrEP before? This is a reasonable approach, as he may have been educated on this before and elected not to take it. This is also a non-judgmental way to gently probe what he knows. Well, it turns out he has never heard of this before. No one has brought this up with him, and he is interested. You teach him how to take it, send the prescription, and give him written information about it like this. This is a dot phrase that I have in Cerner for easy access by just typing .hiv prep. He thanks you for your care, and you notice that as you went through this encounter with him, he opened up more and more and seemed more and more comfortable with you. This is what happens when you practice that universal precautions model with trauma-informed care. Just like putting on gloves to examine every patient, assume that everyone has a history of trauma, address everyone from a perspective of non-judgmental curiosity, and always acknowledge mistakes when you make them, because we all will make them. Showing the patient your own vulnerabilities, like the doctor did in this case, can go far in the trust that they have with you. And now we will tackle our final case of the day, what to do when you are activated at work. And for this case, we're going to travel back up to labor and delivery. So you're a doula working your shift and caring for a 29-year-old having her second baby. She's term and in labor, and you are helping her through her contractions with position changes. Thus far, her pregnancy and labor course have been totally uncomplicated, and the mood in the room is chill. Her bag of water breaks, and her pains become constant, and she begins bleeding. All of a sudden, multiple hospital staff run into the room. They quickly get her into the bed and assess her and state that the baby's heart rate is in the 60s. They do position changes with her like this. This is a pic from COVID times, but pretend this is a patient on labor and delivery because these emergencies look pretty much like this minus the personal protective equipment. And this does not help change the baby's heart rate. They check her cervix. She is not yet fully dilated, and she is bleeding heavily and her abdomen is firm. They recommend an emergency C-section for a presumed placental abruption. So she goes from low intervention to very quickly needing high intervention, and it's all happening emergently. You are standing in the background, watching all of this unfold, and you notice you are beginning to freak out. Your heart rate is racing, you're breathing heavily, and you feel very anxious. At first, you can't seem to figure out why you are having such a visceral reaction. You're an experienced doula and have assisted all types of labors before. To avoid having the patient see you like this, you step out of the room to gather yourself. You know you need to get back to the patient, but you need to get yourself together first. That's when it dawns on you. Your birth was also traumatic. You had an emergency C-section, and although you are grateful for your healthy child and healthy self, you remember the fear and the angst you had in your own moments before your C-section. Now, before we continue on with this case, we need to highlight an important concept that is at play here, and it is called activators. An activator is something that reminds someone of a prior trauma or can even initiate a flashback. You may be familiar with these being called triggers, but there's been a push for using the potentially less stigmatized verbiage of activators. An activator can be conscious or subconscious. It can involve any or all of the five senses. It could be a smell, a touch on a certain body part, a certain word, or even the way a certain word is spoken. In our context, this patient is now having an emergency. Multiple people have run into the room and all are performing interventions on her, and they are now rushing into a C-section. All things that are activating you due to your own traumatic birth experience. Activators can occur for the patient at any time, but they can also occur for the provider or any other support people. If we are taking a universal precautions approach, we should also assume anyone in the room, including providers, have their own trauma histories and that we may become activated as well. One of our biggest and hardest jobs as healthcare workers is to figure out how to remain regulated in the presence of someone who is dysregulated. And if we are the ones who are dysregulated, to figure out how to help calm ourselves again when we are faced with an activator in our work environment. So how can you practice trauma-informed care with yourself? These are tools you can use when you are activated at work or in your personal lives. As cliche as it sounds, the first is to take deep breaths. When you're in fight or flight mode, your breathing becomes irregular, fast, short, and shallow. Slowing down and deepening your breath will stimulate your vagus nerve, which is part of your body's rest and digest nervous system. It helps push you back into a more relaxed state of mind. Try inhaling for a count of 4 and exhaling for a count of 8. This slows down your heartbeat, stabilizes your blood pressure, and encourages full oxygen exchange, which of course is critical to the brain's ability to function. Next is distract yourself. When you're in the heat of the intense emotion, distraction is actually a really useful way to regulate your negative feelings. For example, focus on another sensation in your body, such as feeling your weight pressing into your seat if you're seated down, wiggling each toe individually, or lightly rubbing your fingertips together to see if you can feel the ridges of your fingerprints. Next is use your words. Research actually shows that putting your feelings into words, which is called emotional labeling, can lessen physiological distress. When you feel that emotional rush in an encounter, ask yourself, what are 2 or 3 words to describe how I'm feeling right now? So in this case, with your heart racing and feeling anxious, you might say to yourself, I am feeling nervous, scared, and worried. Neuroimaging studies have shown that the act of thinking in words about your emotional state actually helps activate the parts of your brain that control your emotions and help calm you down. The next is to be ready with a script. This is helpful when you'll need to respond right away and won't have a private moment to collect yourself. To prepare for these situations, come up with a couple of go-to lines that will allow you to quickly respond and buy yourself more time. For example, in this situation, consider a few lines such as, I know this may seem sudden and scary for you. Do you want to tell me how you are feeling? Or, would you like me to help you through some breathing to help distract you? Both of these types of statements keep your work flowing, but also deflect what you are feeling and refocus energy on the patient. It is best if you write and rehearse 2 or 3 short lines that feel natural to you and are widely applicable. Next is don't forget to process your feelings. While all of these methods that I've already stated can help you walk back intense emotions, remember that they are temporary measures meant to help you maintain your poise in the moment. Suppressing your emotions has numerous negative outcomes over time. This can be done with writing, drawing, formal counseling, and peer support. Research shows that a peer support and a supportive supervisor is one of the most important things in decreasing burnout and lowering stress. So now that you know a bit about trauma-informed care and how this type of care can be so beneficial in the healthcare workspace, how can you practice this type of care with the people you interact with outside of work and the people you love at home? First, let's remember the ACEs, those adverse childhood experiences. For a reminder, here are the well-studied 15 ACEs that we know have a negative impact on a person's life and health. Let's take a minute and all look at these ACEs again so we can have that refresher. Think about your partner, your friends, your parents, and even your children. What are their ACE scores? How many ACEs have they experienced? Have you ever had an interaction with someone you love where you felt they got unnecessarily defensive and wondered why? Remember that defensiveness is likely a reaction to an activator or what has been previously known as triggers. So what can you do with the folks who matter in your life with this information? The first is to be aware. If your loved ones have felt safe enough to disclose to you their ACEs, be aware of what they are and any activators that may re-traumatize them. Examples of this may include such like flirtatiously pressing yourself against your partner, maybe against a wall, but then they are activated from a past sexual assault and they push against you or lash out at you. You didn't mean anything unsafe by that interaction, but your partner cannot control, help, or stop these activations. but you can once you learn what they are. So be aware. The next is non-judgmental probing. Like we discussed in the second case, be willing to ask questions to better understand someone's perspective and their experiences without judgment. This also helps build that transparency and trust. The next is a willingness to adjust behaviors. This is related to activators. If you do something that you learn activates someone you love, be willing to modify that behavior so that you are actively minimizing re-traumatization. This also leads into your willingness to help build a network of safety around you and your loved ones. For example, if your loved one grew up in a house with substance abuse, actively avoiding situations like that, such as leaving a party where substances are being used, may help your loved one feel more safe and secure with you. The last is to find out what heals them, what strums their moral cord, what speaks to them at their core. For some, it may be volunteering in spaces where they once had an ACE, such as a child who spent time in foster care, who may find peace and healing by volunteering in foster care spaces. For others who also grew up in the foster care system, however, being around the foster care system may be activating. Each person is unique, and each person's perspectives from their adverse childhood experiences will also be unique. Find out what moves them and help pave that path to healing with them. That's all the time we have for today to discuss cases and how to apply trauma-informed care. So I would like to summarize with some quick gems. Trauma-informed care works when you use the universal precautions model. Apply it to everyone. Assume everyone you interact with, including your patients and also your fellow colleagues, has a trauma history, and remember to shift your thinking from what is wrong with you to the more judgmental, what happened to you? Verbiage and set scripts that you can say with clients and even to yourself when you're feeling activated are really important. Explain all recommended exams, interventions, and even expectations during interactions in detail so the patient knows what to expect and what is coming next. Check in frequently with them. A simple, "Are you doing okay?" or "Do you need a pause?" during interaction can feel empowering to the patient, and so does offering them choices. Self-awareness and self-preparedness. Work on understanding your own traumas and activators and find a way to prepare yourself for when you are activated at work or at home. Consent your patients in everything you do. Never assume consent. When you are sharing information with patients, be as honest, transparent, and non-judgmental as possible, and be intentional with this in all of your interactions. Remember to always strive to know more and to get better at what you do. While you are the expert in your field, the patient or client is the expert in their own life. We should all strive to always be looking for ways to make our interactions feel more safe, more welcoming, and more empowering for our patients and for each other. That is the end, and I would be happy to take any questions.
Thank you, Dr. Conklin. I haven't seen any questions come in via the Q&A, but definitely feel free to put your questions in the Q&A. If you'd also like to come off of mute to ask your question, you can use the raise hand feature. It's just along the toolbar at the bottom of your screen, and if you click that, I can unmute you. Also, don't forget you can send questions anonymously through the Q&A box if you prefer that as well.
So while we're waiting for questions to come in, we've talked often about how things can happen so fast and emergently in some inpatient settings, and how it's still possible to practice trauma-informed care in those fast emergent moments. Could you talk about some of your strategies for that?
Yeah, so two of the really big ones for me on labor and delivery as an obstetrician is postpartum hemorrhage and shoulder dystocias. So in the setting of a postpartum hemorrhage, there are oftentimes really invasive things we have to do really quickly to try to stop bleeding. But I have learned over the years that even taking just a moment, I mean, even with audible bleeding, which if you've never heard is like the sound of a hose on a cement driveway, I will take a moment to say, "You are bleeding heavily. This is what I'm about to do. Do you understand?" And usually the patient's like, "Yes, please stop it." But you take that second to say something rather than, we sometimes have to stick our entire arms up the vagina and into the uterus in that setting. But what has historically happened and what does still happen today is that arm goes up there without actually explaining what you're doing. And that is very violating and very painful. So I take that second to say to the patient, this is what's going on. This is what I need to do. And sometimes patients need a second and I give them that second. I had a, patient who had DIC and was, bleeding heavily. And we got to the point where I needed to put a Bakri balloon in and she did not have an epidural. And I had told her before the delivery that this was probably going to happen. And so when it was time, she said, okay, just give me a minute. And I gave her that minute. She was okay. Blood was still flowing as far as transfusions were concerned. So I gave her that minute. Did I want to put that Bakri balloon in right away? Of course I did. But I gave her the minute and it mattered to her, right? And afterwards, actually, all the other ICU docs and everything in the room said to me how they appreciated how I kept everything calm and kept the patient informed. And so it is totally possible in those emergencies to have those very quick conversations about what I need to do and why. With a shoulder dystocia, it's the same thing. I'll say, the head is out. I haven't been able to get the baby delivered by normal maneuvers. This is what we're going to do next, because one of the first things is McRoberts. So we shove their legs back quite far. Again, it's violating to the patient. We know why we're doing it. They don't. And it feels awful when you're stuck there on the bed as the patient and the 4 people are holding you down in this way. So I say to the patients, this is what's going on. This is what I'm going to do. This is why. And then you do it. Now that didn't work. I'm going to stick my fingers this way, into the vagina and do this twisting motion. As long as you say that before you do it, the patient knows why it's happening. And that's the key. And then I always sit down afterwards once that postpartum hemorrhage is stabilized or once that shoulder dystocia is resolved and the baby's okay. I sit down with them afterwards and I debrief with them immediately and go through it. Again, it might take 5 minutes out of my life, but it is so, so, so vitally important to that patient.
Do you know if there's been any progress in medical schools or anything to teach more of these patient care, trauma-informed practices?
Yes, I'm working very hard at it.
We're all working on it.
Yes, in general, there's I would just say, kind of being aware of educational opportunities in academic spaces across the country. It's not the standard of care yet to have these kinds of lectures and this type of training, but it is becoming that. It is slowly improving everywhere.
That's awesome. I was just curious.
And anyone on the webinar that has a voice or a position of power, everyone has a voice. But go ahead and use that in any of your communities, in any of your settings to really demand it, because we understand that there are tests people are working towards and standards people are working towards. And at this point, TIC is not a required component. So whether it's advocacy at the state, advocacy within your regional academic institutions, or within your institution in which you're employed, these are all points where we want to get the word out and make sure that it becomes standard.
Question did just come in. Someone asked, how do you address a team member who isn't practicing trauma-informed care in a situation in front of a patient?
Generally, I don't do something like that in front of the patient. What I try to do is model behavior. So when I see that kind of stuff happen, I will try to step in when possible to provide that trauma-informed care, because I think one of the best ways we can teach it is to show it. It's one thing to write it down on paper and to talk about it, but it's another thing entirely to see it in action. And so I do try to model that behavior with providers.
Can you expand on that, Dr. Conklin, thinking, what about power dynamics, right? We know that leveling power dynamics matters, not just with providers and patients, but also within the healthcare team. But what happens if it's me as a nurse witnessing something where the physician is not practicing? What's the best way to try to approach that?
I think the best way to do it in a way that doesn't offend the ego, shall we say, is to say, well, Sally, the patient, would prefer if we did this. Would it be okay if we tried this? For example, like some patients where we walk in and say we want to start Pitocin, but the patient really, really, really wants to avoid Pitocin and hasn't actually shared that with anyone except their nurse. So the nurse knows that. So she has she should be advocating for the patient, but to say something like, we're not doing that, is not really beneficial to anyone, right? There shouldn't be dictating to people. It should just be a team conversation. And so just saying, the patient would really love to try nipple stimulation first if you feel like that's a safe option, is a great approach, right? You're not offending anyone, you're not being mean, and you're not dictating to anyone. And it is a safe option. We know because this, baby's category 1 and everything's fine. And, the big water's not broken and there's no infection risk. And there's no reason why we can't do that. So say it in that way, like Sally would really like to try nipple stimulation before we get to Pitocin if you think that's a safe option. kind of corners the provider to say, yeah, actually it's fine. We can do that. Sure. And that also gives that person who may be not practicing trauma-informed care sort of an out to save face in front of the patient too.
While folks are thinking of any other questions they may have, I'm just gonna put the evaluation or the survey link for the evaluation for this webinar in the chat. So definitely feel free to fill that out for us. We really appreciate it. Helps us form future events. So. And I know there were some questions about the PowerPoint slides earlier as well. I can include that in the follow-up email in addition to the nursing contact hour form. I'll add those in too.
And of course, this webinar will be available as a YouTube video on the HCET YouTube website in the near future.
Yep, should be up probably by early next week if I had to guess.
Any other questions anyone can think of? A question was asked, is this worth CE? It's worth nursing credit hours.
Yep, nursing contact hours are available for this. You just have to have been here for the whole webinar, complete the evaluation, and then fill out the nursing contact hour form, which I'll send. And yes, there is a certificate once you turn in that form to our colleague at HCET that handles all that. She'll send you your certificate. And it looks like another question came through in the Q&A. How can we advocate to make this the standard of care and education?
So that's a great question, and it really boils down to what access you have. For example, I'm in an academic institution with a fairly large resident body, and so this is being incorporated into resident lectures. I obviously teach it, on the floor when I'm rounding with patients and caring for patients in delivery, and I do like the family-centered C-section, so I'm teaching those techniques as well. So for me, I have a good access point. Some people are in private practice, so that might be a little bit harder. You have to get buy-in from the providers that you work with. If you have access to educating up and coming learners, I strongly encourage, creating lectures. I'm happy to also provide lectures. I'm sure HCET and MTITC would be willing to also participate in providing that education and training. But wherever you have access to that education and the ability to teach young folks with sponge minds to absorb it all is ideal. But it can still be done with people who've been practicing for 20 years. I didn't even hear about trauma-informed care until I was done with residency. I'm constantly working on and evolving it, and I will forever. That's what lifelong learning is about. So any opportunity you have to create lectures, create educational opportunities, provide in-person training, provide on the fly, real world lessons during patient care to learn by example is also very important.
There's also data not only around how much this improves the patient experience and continued engagement in healthcare and all these things, but also how much it impacts staff satisfaction, retention, lowers burnout, all of these things that sometimes speak more to that administrative mind. And that's not the worst thing to mention, right? It's maybe not what matters the most to me or to us, but it matters to some folks. And you can go ahead and use that to speak to people at different levels of the system.
I also will just say a point on that. Sometimes I feel like we're told we have to change the way we do things, whether it be how we function in the EHR or what orders we place or whatever. And some of those things that are dictated to us do in fact worsen burnout, right? They make things harder for us. This is not one of them. Trauma-informed care is literally the opposite. The more we practice it, the less hard our job becomes. In my opinion. Been doing it for 10 years.
And then as far as handouts, there's a question about handouts that people can use. Yes. So they are coming soon. We are just working on getting them translated into Spanish and then putting them onto our website. So again, if you want to follow through that QR code or email updates at HCET, .org, and we can get you on that list. As they become available, they will be pumped out on all our socials and all the things. And if there is a certain type of handout that you are interested in, we would love to hear about it. So again, you can contact me, you can fill out that survey, and we will work to develop it so we can best serve you and your patients and what you need.
Someone asked about resources available for incorporating this into sim activities. Do you have thoughts on that? Is there any trauma-informed care training center sim activities you could share?
We don't have anything specific to sim activities. You know, I do think this is often one of the things that is included when you have the opportunity to work with like live models in a like practice setting. Again, we're happy to engage conversation with anyone with any kind of program, but nothing specific to sim right now.
I think we should consider adding that to our, the survey that of ideas that they want for MTITC. I think we could easily create sims for this.
You two might have covered this and I was writing my other message, but someone asked if there's anything that can be done with a badge buddy.
Writing it down. If there's verbiage you would like, let me know.
May I ask what a badge buddy is for, I don't know, so I'm wondering.
Something like this. I assume they mean something like this, like, sorry, this is blurry, but how I have my,
Oh, cute.
my
Okay.
badge buddy.
That's a great
Emphasize
idea.
that they practice trauma-informed care. I think that's a brilliant idea.
Yeah, I love that.
I like it.
All right, any other questions, comments, suggestions?
Hi, Laurel and Tracy. I just saw Laurel comment. They're midwives I used to work with in Michigan. Thank you, Diana, for your comments as well.
Awesome. Well, I will follow up with y'all via email, send that nursing contact hour form, PowerPoint slides, etc. And please feel free to email us at updates@hct.org so we can add you to our internal email list. I think that was everything. Have a good rest of your day, everybody. Thank you.
Bye.